Last but not least, Regina Dalmau from Madrid will talk about special features of cardiac rehabilitation after myocardial infarction in women.
Good afternoon, everyone. First of all, I would like to thank the invitation to the organizers, Antonia, Mila. It's my pleasure to be here today in such an amazing venue and in such a beautiful city. So let's talk about cardiac rehabilitation in women. Does it work? Oh. No avanza. Uy, no me funciona. Se puede acabar la pila. It's next, no? No hay más. Okay. Thank you. First of all, some facts and a little reminder about cardiac rehabilitation. Cardiac rehabilitation is a multi-component and multidisciplinary approach in secondary cardiovascular prevention aimed at reducing adverse outcome in patients with coronary disease or with heart failure. And it also can improve the health-related quality of life and the adherence to lifestyle and to medication. Cardiac rehabilitation is supported by a very strong body of evidence and very strong recommendation in guidelines in both contexts, coronary disease and heart failure. And all this because of this important body of evidence on the reduction on cardiovascular mortality and hospital readmissions. But despite this strong recommendation in guidelines, and despite all its benefits, it's true that cardiac rehabilitation is underused, and a large proportion of patients that have an indication to go to a cardiac rehabilitation program are not referred, and a low proportion of patients finally enroll a program. Here we are facing a gender gap. We know that cardiovascular disease is the leading cause of death in women and that acute coronary syndrome is among the main burdens of disease. We also know that women usually undergo fewer diagnostic and therapeutic interventions for their heart conditions, and also that their awareness of risk is disproportionately low. Cardiac rehabilitation programs are strongly recommended in guidelines, as I mentioned, but for diverse reasons, women are less likely to be referred to cardiac rehabilitation than men after their events. And even after being referred, their completion rates and their adherence is lower compared to men. Many reasons may be involved in this gender gap. But we know, and we have already mentioned this issue many times today, that there are some age and gender differences in medical adherence after MI, and we know that women do not receive optimal treatment. This important gap is one of the reasons that women are less likely to be referred to cardiac rehabilitation as an important therapeutic procedure after myocardial infarction. In this registry, what we can see is women, young patients and elderly patients had a lower medical adherence, and the larger differences were observed in the use of statins in women. So we have lower referral rates, and even after being referred, women have lower enrollment rates and lower completion rates. And all this contributes to worse outcomes in our women patients. But we need to bear in mind that clinical outcome improvements after cardiac rehabilitation are at least as great in women as in men. In this large cohort study with more than 25,000 patients, what we can confirm is that the rate of referral is lower in women, but very important. The attendance to cardiac rehabilitation is associated with a significant mortality reduction in women that is comparatively better than in men. And the higher benefit is observed in women that complete the program. Let's talk about the barriers. We have many kinds of barriers, and this is quite complex. Some barriers are medical related, some psychological related, cultural. Some barriers are more related to the patient, some other to the caregiver. But we have a cluster of issues such as musculoskeletal issues, transportation issues, a poor physical performance, family obligations, comorbidities, or a lack of interest in women. And something that we can affirm, I think this is still very patent, is that even nowadays and in many cultures, women are usually more focused on taking care of the others, of the rest of the family, than of themselves. We also need to talk about a sex bias in the referral of women to cardiac rehabilitation. This is a meta-analysis, and what we can observe is that in different settings, different countries, men were approximately 1.5 times more likely to be referred to cardiac rehabilitation than women. And according to the authors, approximately half of the sex difference in referral can be attributed to true discrimination. This is something to think about. Is this conscious or unconscious? Well, we don't know. But if cardiac rehabilitation referral is related to lower mortality, we need strategies, such as systematic referral strategies, to close this gap. Another issue is the treatment risk paradox. According to this paradox, patients that have a poorer functional capacity or psychological symptoms such as depression or anxiety, and mostly women, are less likely to have an access to the evidence-based therapies. And I'd like to highlight that cardiac rehabilitation is beneficial irrespectively of the functional and psychological status. And I would affirm that cardiac rehabilitation is even more effective in women with a poor functional status and with psychological issues. When considering the predictors of non-referral and non-completion in women, as we can see, we have the age, the comorbidities, and heart failure, systolic heart failure. And what we can conclude is that we are facing a contradiction, because the women patients that are more in need of cardiac rehabilitation have a poorer access to the programs. Summarizing these barriers, referral barriers, the excess cardiovascular morbidity and mortality experienced by women with coronary artery disease is underappreciated by healthcare practitioners. This is a sex bias we've talked about many times today. There is a lack of strong physician recommendation of referral to cardiac rehabilitation. Still, nowadays, some of our colleagues do not rely on cardiac rehabilitation. There are some misconceptions of cardiac rehabilitation, and it's true, this is an important issue as well, that there is poor availability of cardiac rehabilitation units. We need more. And considering the completion barriers, we've talked about comorbidities and older age. It's true that women often don't have enough information about the role of cardiac rehabilitation, and sometimes they have negative beliefs or perception about cardiac rehabilitation. Sometimes they perceive exercise as being tiring or painful. And the social factors, very important. Transportation problems, family obligations, house chores, lack of social support, and financial concerns in the settings where cardiac rehabilitation is not reimbursed. But let's talk about the solutions, because we have solutions. Whenever every patient that has an acute coronary syndrome is automatically referred to a cardiac rehabilitation program, we will be able to close the gender gap. And let's make cardiac rehabilitation more accessible, and we shouldn't have any waiting list in our cardiac rehabilitation units. We should offer the opportunity to complete a program as soon as possible after a hospital admission, because each day of enrollment delay translates into an important decrement in the likelihood of the cardiac rehabilitation enrollment. So cardiac rehabilitation, yes, and as soon as possible. We could consider whether women-only programs are valuable. Well, it's true that some women could feel intimidated by the presence of men in the groups of cardiac rehabilitation, and this is perhaps more important in some cultures. And in fact, there are some studies that have explored the differences between different kind of programs, home-based programs, mixed-sex programs, or women-only programs. And in fact, every supervised cardiac rehabilitation program is effective in improving physical performance and quality of life, but women-only programs may confer an advantage for anxiety and depressive symptoms in women. And also, there is something very tangible for all of us. When we go to a gym, we are all aware that some physical activities are more appealing to men than to women. We all know that this is a reality. So, perhaps we can tailor the programs to women's choices. And there are some studies that have explored this possibility. And for example, Zumba fitness has been studied in the frame of cardiac rehabilitation as a possibility. And there is an important body of evidence supporting home-based cardiac rehabilitation in order to make cardiac rehabilitation more accessible to our patients. And as it is stated in this document from the American societies, these kind of programs, home-based programs, could target specific patient subsets that are less likely to enroll and complete the conventional programs, such as ethnic minorities, women, older adults, or rural residents, or economically disadvantaged individuals. So, another important issue in order to try to make cardiac rehabilitation more available. And summarizing how to overcome these barriers, systematic approaches to cardiac rehabilitation are very important. An automatic cardiac rehabilitation referral system is an important issue, or liaison nurse to patient communication after an admission, an early post-hospital enrollment. And I would say that whenever cardiac rehabilitation referral and completion is a standard of quality in a cardiology service, perhaps we will improve the rate of enrollment in patients with an indication. And how to overcome the completion barriers. We have mentioned the importance of reducing the time of enrollment. We should offer information campaigns to patients about cardiac rehabilitation benefits. We should try to increase privacy in women and offer a wider variety of exercise modalities to women, more appealing to women. And also the alternative cardiac rehabilitation models, telerehabilitation, and we should seek family support for these women to be more able to attend the programs. So, this slide summarizes the cardiac rehabilitation process, from the first indication to the referral, the enrollment, the adherence, and finally, the improvement of the cardiovascular outcomes. So, at the top we can see the barriers we have mentioned, and at the bottom, the solutions. I will give some conclusions. Despite its proven benefits, women's access to cardiac rehabilitation is still suboptimal. Referral strategies such as systematic referral have been advocated to improve the access to cardiac rehabilitation in women. A better understanding of the nature of cardiovascular disease in women, as well as women and physical and psychosocial characteristics, is warranted in order to tailor the programs to women's needs. And further research is warranted on the impact of novel cardiac rehabilitation delivery models, such as home-based cardiac programs, on the gender gap in cardiac rehabilitation participation. And a final message: nothing is impossible to women. So let's improve the access to cardiac rehabilitation for our women patients. Thank you.